So with that, we're going to go ahead and just show you how actually it works. And so we're going to walk through a couple of cases, present some cases, and we have Dr. Grievous from the medical oncology, myself, Dr. Liao from radiation oncology, and myself. So, and this is truly how it works in our conferences. So first case, this is a 72-year-old gentleman with a history of non-muscle invasive bladder cancer. Last fall had TA high-grade urothelial carcinoma of the bladder, underwent induction BCG 6 weeks worth. Then was found on surveillance cystoscopy to have recurrence of the TA high-grade disease. Earlier this year, underwent a second course of induction BCG, 6 more weeks of BCG therapy in the bladder, and then was found, unfortunately, now to have progression to T1 high-grade urothelial carcinoma. We get several of these patients also referred into our clinic to, this is a very common scenario that we face and is a challenge to manage. Because what do we do next? And there are different options, and not one option is right for everybody. Do we do more intravesical therapy? Do we talk about upfront cystectomy at this point? What's the role for chemoradiation? And finally, clinical trials. There are lots of different intravesical therapy options, but I'll say in this case where someone has failed 2 consecutive courses of BCG, we would not recommend additional BCG. There is talk about adding interferon, although the additional value of adding interferon over BCG alone remains unknown, although there are some data. Valrubicin for patients with CIS has been shown and approved by the FDA. This patient didn't have CIS. This was just TA to T1 disease. Unfortunately, even with intravesical valrubicin, the overall complete response rate at 1 year is quite low. Similarly, another intravesical chemotherapeutic agent, gemcitabine, another publication, a phase 2 study showing that, again, there is a subset of patients that will respond, but in the 20 to 30 range is not where we want to be for most of our patients. And certainly there are other exciting agents that are available. And so we often talk in this setting about should we go for cystectomy in someone that has failed intravesical therapy. Not all patients are candidates for cystectomy for health reasons or don't want them, but want to have a cystectomy. We consider a lot of factors about the pathology, about the symptoms, and about the patient goals for deciding for cystectomy, because clearly it is a significant operation on patients. And so it then begs the question, when we're faced with this patient, Dr. Liao, what can we or what could we offer for as far as chemoradiation for patients?
So typically for earlier stage disease like this, radiation therapy or chemoradiation hasn't had a standard role. So it's not technically standard at this stage of disease, but it holds promise, I think. And it may be an effective option when you look and extrapolate from our experience with a little bit more advanced disease where it's actually muscle invasive. And in that setting, we'll go over a little bit later, there is evidence that you can have successful bladder preservation with the strategy of chemotherapy and radiation therapy. There is a little bit of data, though, looking at this, and the Europeans have had some track record with this. One of the largest series comes from the German group. They took patients exactly in this picture that had T1 disease that was either recurrent or high grade. And in 141 patients, they were either patients who had decided that they would not undergo cystectomy or may not have been healthy enough for it. And they underwent mostly chemoradiation. Some had just radiation therapy alone. And they tracked the patients with follow-up for over 5 years and found there was a pretty high complete response rate with treatment that about mirrors our experience in muscle invasive disease, if not better. So the complete response rate was near 90%. Ultimately, there were about 30% of patients that had some recurrence later on down the road. But this led to pretty good outcomes as far as cancer survival outcomes. Where at 5 years, it was about 80%, and at 10 years, about 70%, which is close to the outcomes about other strategies. And most rewardingly, there was a large proportion of patients that had successful bladder preservation. About 80% of survivors had a preserved bladder. And importantly, it was a bladder that worked. So it's the majority of patients were pleased with their overall level of urinary and bladder function. So this is something that we're excited about, and we were participants in a cooperative group trial, which is a study that involves multiple hospitals trying to look at a question carefully like this. So this was a small study we briefly had open in our institution that was looking at patients that had T1 bladder cancer, often those refractory to BCG, and looking at whether this could be a safe alternative to cystectomy. And we looked at patients that had a TURBT and then underwent full dose radiation therapy with concurrent cisplatin chemotherapy. So this mirrors the strategy that we use in muscle invasive bladder cancer. So unfortunately, it was a little bit difficult nationally to enroll onto the trial with just the timing of it, but we were able to successfully get one patient onto the trial that I think has been a long-term survivor of bladder cancer with successful bladder preservation. So it's something I think we should look into further.
Dr. Greaves, what about clinical trials? What about in this setting, the other option for patients?
So clinical trials are always something we look at, and in academic institutions, but even in the community, there is significant attention about clinical trials because that's a vehicle how we make progress, how we define new therapy. So definitely we always think clinical trials across the spectrum of disease stages in bladder cancer and other cancers too. Specifically to your question now, in this particular context, there's some clinical trials that are of interest. Some examples will be shown here in that slide. There is this important trial from the SUO. There is a Society of Urologic Oncology is utilizing an adenovirus vector. There is a study that Dr. Dine from MD Anderson is leading with Instiladrin, which is an interesting therapy trying to pretty much stimulate indirectly the immune system in the bladder microenvironment. There was the results of that phase 3 trial is still not reported, but the scientific community is looking into this Instiladrin trial and to see whether there is any meaningful results in that context. There's definitely trials with immune checkpoint inhibitors. I'm going to show you a few slides in a moment how these checkpoint inhibitors work. These anti-PD-1 and anti-PD-L1 agents, and there's also a bunch of other trials. For example, trial with interleukin-15, which is it's a chemical cytokine, we call it, which stimulates the immune system in a very robust way, so the immune system can be energetic, activated, and try to go after cancer cells inside the bladder. There is also a study looking at the biologic agent called Vicinium. Also, the results of that phase 3 trial, I think, are still pending. So definitely significant interest in the research in that context. To focus a little bit more on the immunotherapy question, since this attracts a significant attention, there are many questions with recent Nobel Prize being given to two individuals who discovered some checkpoints, breaks of the immune system. So the immunotherapy, usually the immune checkpoint inhibitors work indirectly through activating the immune system. Immunotherapy usually does not attack cancer cells directly as opposed to chemotherapy, but tries to activate the immune system so the immune system can get energized, as I mentioned before, invigorated and go identify, discover, and attack cancer cells. So it's an indirect way to go after the cancer. I mentioned a minute ago that two individuals received the Nobel Prize a few months ago because they discovered two of the breaks of the checkpoints of the immune system. I always use the analog of a car or a vehicle when I talk to the patient, when I describe these agents. The car, the one vehicle, has accelerators, gas pedals, and brake, right? The checkpoint to stop the car to avoid going too fast. The immune system, in a similar fashion, it has many gas pedals, many accelerators that stimulate the immune system to go after, infectious agents, cancer cells, but also has these checkpoints, these regulatory control molecules that are the brakes of the immune system to avoid any autoimmune reactions, because if the immune system, our car, goes too fast, we may have an accident, meaning the immune system attacking our own body, our own self, our own organs. So to avoid this autoimmune reaction, we have the checkpoints. So the cancer cells are tricky because they upregulate, they try to increase the expression of those brakes, the checkpoints of the immune system, so they can evade the immune system surveillance. So the question here is, if you discover those checkpoints these breaks of the immune system, you can potentially block them, so you can shift the balance towards the accelerators, the gas pedal, so the car can go faster against the cancer. So this figure that you're going to see here in that slide depicts various checkpoints. This PDL1 and PD1 is one example of two molecules that they come together. PDL1 can be expressed by cancer cells, and PD1 in the membrane of the lymphocytes, the soldiers of the immune system, right? The cells that are going after the cancer cells. So when we have an overexpression of this PDL1 checkpoint by the cancer cells, this binds to PD1 and suppresses, cools off, cools down the immune system, so the cancer cells can try to avoid it. So if we block this interaction, then hopefully we can stimulate the immune system against the cancer. So we have these checkpoint inhibitors that inhibit either PDL1 or PD1. And one example of that is this molecule called pembrolizumab, which is depicted in that slide. If you give that drug intravenously once every 3 weeks, you aim to stimulate the immune system against the cancer. So this particular clinical trial I'm showing in this slide, and it's an example, and there is a similar trial, very similar with atezolizumab that is being done, and the name of that trial is SWOG 1605. And this trial is testing these drug checkpoint inhibitors in patients who had, as Dr. Wright mentioned, unresponsive to BCG, recurrent non-muscle invasive bladder cancer. Cohort A includes patients with carcinoma in situ in the bladder. Cohort B is patients with what we call papillary tumors without carcinoma in situ, CIS. So the question here is, pembrolizumab is an alternative option for those patients who either cannot get cystectomy, removal of the bladder, or they're too frail to get it, or they refuse to do it, because cystectomy is usually the way to go in this BCG unresponsive scenario. This trial has reported some early results, and there is some promising activity with that drug. In about 3 months time frame, about 4 out of 10 patients had no evidence of cancer. The question is, how long can this result last? And this question of duration of response, how long the results last, is an active open question that I think is going to give us an answer down the road, whether these agents may have some lack to get approved for that particular setting in that particular question. So it's very, very exciting, I think, to put these patients on clinical trial. We have this trial open at the University of Washington. Dr. Wright is actually the principal investigator in our center, and we have a number of patients who actually have been enrolled, and we continue actively enrollment of patients in this particular trial, again, trying to evaluate whether this checkpoint inhibitor, pembrolizumab, can have a significant benefit in those patients. So we follow the patients with cystoscopies, biopsies, urine cytologies, and CAT scans to see if there's any activity against the cancer. Again, that's an example of, there are many other trials in that context, but that's one of the examples we have open here.
So I think, we go through here, we've looked at all the different options for this patient, and I think we would agree that in this case, if the patient is willing and healthy enough for it, we would recommend as a group a radical cystectomy for this patient. However, if they were not able to, or refused, we would then recommend clinical trial most likely. And then if they weren't eligible for a clinical trial, the consideration for other bladder preservation options. Would that be fair, guys?
Absolutely.
I'd agree.
I think that standard of care is radical cystectomy. Yeah. If someone cannot do it, is too frail, or not refuses it, clinical trial, and then we go to other options as a third choice.
Great.